Pancreatic cancer is becoming almost epidemic in the United States. 2 years ago, it passed breast cancer and is now the third most common cause of cancer-related death in this country. And it's projected that it will pass colon cancer by 2020, 2022, and become the second most common cause of cancer-related death. Only about 20% of people, when they are found to have pancreatic cancer, are suitable for a potentially curable surgical resection. Once that occurs, the majority still recur, their disease recurs, and they're not cured by the operation. So there have been efforts in the last 15, 20 years to try to give chemotherapy after the surgical resection in hopes that that chemotherapy might enhance the likelihood of cure.
This was a large randomized phase 3 trial that looked at patients who had undergone resection of pancreatic cancer. It was a large trial, 500 patients, and they were randomized to a single agent gemcitabine approach versus a combination approach of FOLFIRINOX, which is a combination of 3 chemotherapy drugs, namely 5-FU, oxaliplatin, and irinotecan. The primary objective of this study was to measure disease-free survival in these patients after undergoing resection, with secondary endpoints being overall survival and metastasis-free survival.
Almost 500 patients were included, so it's a large randomized phase clinical trials. The endpoint was disease-free survival, and it showed a statistically significant benefit for the combination of 5-FU, leucovorin, irinotecan, and oxaliplatin compared to gemcitabine, nab-paclitaxel. And the difference is big because the disease-free survival is about 12.8 months for gemcitabine-based treatment versus 21.6 months in FOLFIRINOX. This is a hazard ratio of 0.59, which means 40% improvement of disease-free survival in this patient population. This translated also in a significant overall survival benefit with a difference of 20 months, which is absolutely impressive in this disease, from 34 to 54 months with a hazard ratio of 0.6. So 40% improvement of overall survival. This data will be practice changing in a way that there is now data that this triple combination has a significant impact on overall outcome, disease-free as well as overall survival in this patient population.
FOLFIRINOX chemotherapy is a combination chemotherapy regimen with 4 different drugs, and it does have significant toxicities. So I think that, in terms of what we've seen with many other types of cancers, is that the better chemotherapy regimens did have an impact in terms of improving survival in the adjuvant setting. The challenge is going to be trying to select the best patients to be able to tolerate an aggressive chemotherapy regimen after surgical resection. Because what we've seen with many different types of cancers is that after surgical resections, there's a lot of potential GI problems that occur after surgical resection that they may not be able to actually complete their chemotherapy regimens. So being able to actually select the best patients, I think, is actually very important.
I think one limitation of this study is it uses an old standard in the adjuvant setting, which is gemcitabine. There has been data since that has published on the improved outcomes of combining gemcitabine with the oral chemotherapeutic Xeloda or capecitabine. And that certainly has become our new standard of care for patients in the adjuvant setting. And so this study did not use gemcitabine and capecitabine as its control arm. But I think certainly we have options now, and I think as oncologists it's always good to have options. I think when patients come to us in the adjuvant setting, based on their performance status and how they're doing in the post-operative setting, we'll certainly have options now that range from a single agent approach to a more aggressive 3-drug approach. We'll also have gemcitabine and Xeloda to fall back on as well.
I don't think we can give this triplet to every patient. A lot of overall performance rate of the patient, the ability of laboratory results, normal liver and kidney function will impact the choice if patient is a candidate for a more toxic and more aggressive regimen. But now we have data justifying that it should be considered for the right patient with this incredible 20-month survival difference.
I certainly think this will be practice changing. I think for those of us who treat pancreatic cancer, this is a patient population that still is fraught with a lot of frustration because unlike other cancers, catching pancreatic cancer at an early stage to where surgery is possible still does not give us the long-term cures that we enjoy in other GI tumors. I think what will be interesting in future studies will be whether moving a combination approach like FOLFIRINOX to the neoadjuvant setting, so prior to surgery, will give us the same outcomes that we see in this study, but maybe better tolerated for patients who haven't yet undergone surgery.
The impression that we have at this point is that the FOLFIRINOX will increase this considerably more, thereby enhancing the likelihood that surgery and the chemotherapy will for the first time cure a significant number of people with this dreaded disease.